I'm Dr. Hansa Bhargava, Chief Medical Officer of Medscape Education. I'm delighted today to talk to my friend and colleague, Dr. Colleen Kraft, about a serious condition, schizophrenia. Colleen, thank you so much for being here today.
Well, you're welcome. Thank you for the invitation.
Can you tell us a little bit about your background? I mean, you've got a star-studded background. I know that, but I'm sure the audience would be interested too.
Sure. I've been a pediatrician for 34 years. I am currently a professor of pediatrics at the University of Southern California at the Keck School of Medicine, and I teach pediatric residents at the Children's Hospital Los Angeles, and have spent my career really integrating developmental and behavioral conditions into primary care pediatric practice. And we met when I was president of the American Academy of Pediatrics in 2018.
Yeah, absolutely. It's been such a wonderful journey to know you and to follow you in your work. So let's get right into it. We both know as pediatricians and as physicians how much mental health is an issue these days, but I know you've been doing a lot of work around schizophrenia. Can you tell us a little bit, if you don't mind, about how that work started?
Sure. Well, you and I met in April of 2018, and you interviewed me for Medscape when I was president of the American Academy of Pediatrics. And about a week after that, my 28-year-old son, who was a very successful artist and musician and real estate agent, had his first psychotic break and was hospitalized. And he came back to California with me, and we saw private psychiatry for a couple of years and community mental health for a couple of years. And he didn't get better. He had delusions and hallucinations, was on medication, didn't like the medication, just didn't get better. And so we eventually wound up at UCLA in a clinical trial for schizophrenia. And that is when he got his diagnosis of schizophrenia. The clinical trial was very intensive, helpful. I mean, he had saw a psychiatrist every week, a psychologist twice a week for therapy, was involved in neurocognitive training, and was involved in exercises. And he got a little bit better, but never really got back to the point where he was before his first psychotic break. He had some really brilliant art that he did during this time, and I think really reflected where his mind and where his illness was at this time. And sadly, after 4 years, took his life by suicide, I think in a psychotic moment. So since then, I've really been talking about schizophrenia and how we don't have the right treatments for these patients. About 0.8 to 1% of our general population has schizophrenia, is diagnosed with it.
Wow.
A third of these people never get better. And that was my son.
That's just devastating, Colleen. I am so very sorry that this happened. And, looking back at your journey as a parent, you obviously did everything that was in your power. And that must be so difficult knowing that you did everything in your power, and yet this is the outcome. It's so kind of you to share this story, to help move this forward. I mean, I know
Well,
that our
it's
team really
so
appreciates it.
important, so important because, I'll tell you a couple of other things. I was at the Pediatric Academic Society meeting this year in Denver, and no fewer than 8 of our pediatric colleagues came to tell me that they have a Tim in their basement, or they had a Tim and he died by suicide. This is rampant. This is rampant. And, we have,
Wow.
yeah, it happens to so many people, but the shame is in secrecy.
Yeah.
And so we got to stop that. We got to get this out and talk
Yeah.
about our loved ones who have this disorder, and what were the early signs, and what can we do to help them out.
What do you think is needed to improve these standards of care? What can we do as doctors and providers to close these gaps to help those with this devastating illness?
So that's a great question. I think the first thing that we have to do is understand that even the label of schizophrenia is stigmatizing. And it took 2 years for my son to be diagnosed because nobody wanted to tell me it's schizophrenia. I mean, because we think of this and we think about the psycho killer, we think about the homeless person, we think about all of these awful things along with the diagnosis of schizophrenia. You know, Hansa, it reminds me a lot of 20 years ago when we first started diagnosing kids with autism. Nobody wanted to hear that diagnosis because the parents felt like they did something to cause it and there was nothing there to treat it. And 20 years later, we have lots of early intervention. We have lots of really great therapies with these kids. We have the understanding in early intervention and in early childhood special ed preschool that these kids have great strengths and that we can help to work on some of the deficits that they have so that they can be very functional members of society and have friends and have a good future and a good life. We need the same for schizophrenia. So the first thing that we have to do is not be afraid to diagnose it and to know that we've got treatments that are effective and we don't have them right now. We just don't. We don't have the medications that can really help these people. And we know that some of the therapies work, but a lot of these people need medications too. So we need a whole different way of treating these people and understanding their condition and understanding that they can be independent. The thing that scared my son the most was being hospitalized or being institutionalized. And he would sometimes look at people on the street who were homeless, and that scared him to death. And we need to not have that as a future and a vision. We need to make schizophrenia something that we talk about, that we recognize the symptoms early, and that it becomes a diagnosis that's not hopeless for these kids and these people.
We do have work to do, and you've talked about so many things about it, but just to summarize some of the major issues, as you said, Colleen, is basically the stigma, raising awareness, and of course, finding the right treatments for these kids, young adults who really, need to have that to be functioning, as you said. I can't even imagine the tough times you've been through, and we are so grateful for you to share this story, just to shed light on this issue and hopefully help to move it forward.
Thank you so much. If my son were to have a voice, he would tell us the same thing. And that what we can do now is take his voice and move it forward and really demand that we find cures for schizophrenia.
Absolutely. Thank you so much, Colleen.
Thank you.
And I'm excited to have Dr. Steve Brannan here today to talk about schizophrenia and the gaps in patient care. Steve, welcome.
Thank you. Thanks, Hansa.
So before we get started, I'd love for you to tell us a little bit about your background.
Sure. Well, I was trained as a psychiatrist and then got involved with science, did a research fellowship for a couple of years, was involved with neuroimaging for quite a while. When I was a senior resident, something novel called Prozac came out. And so my next couple of years were spent with a lot of SSRIs, and I focused on anxiety and mood disorders. But because of the neuroimaging and the way the brain works with all the neurotransmitter systems, if you tell me what the issue is in the system, I have a good chance of figuring it out. Also worked a lot with schizophrenia patients at the time, and then got involved with industry later on, first with Eli Lilly and then a number of other places, and have ended up here at Karuna in the last 5 years, and I'm Chief Medical Officer here.
Well, you've been doing a lot of work in many areas, I can see. Let's focus in on schizophrenia. Millions of our patients are suffering from schizophrenia. What are the most important issues that we need to address right now?
Yeah, it's really a bad disease. It has persistent problems with what we call positive, negative symptoms, as well as cognition. It's also a lifelong illness, so it happens early on, really in the teens and 20s for most individuals, Sometimes it's not picked up as early. Seems to be getting picked up earlier in men than women. Could be that men, it starts earlier, but we're not quite sure. And then it sort of doesn't get a lot better and sometimes gets worse over time. So, and we do have some treatments for it, but mostly for what we call the positive symptoms. And so a lot of the things that keep people really from getting better or doing well in life are more like the cognitive problems and the negative symptoms.
What are the treatments that are out there, and what are the gaps in treatments? What do people struggle with, and what do our clinicians who are listening right now, what can they look towards for some positive news around this?
The mainstay of treatment has been what we call antipsychotic medications, or antipsychotics for short. All antipsychotics, and the older ones in particular, have some significant side effects. The main ones is that you have like sedation, you have EPS, which is really motor symptoms, can even progress to tardive dyskinesia. And we recently have some medications that can help with that. And also the newer antipsychotics tend to cause weight gain and metabolic syndromes.
Yeah, I mean, the balance between controlling the symptoms and the side effects, right? And then also the functionality of the patient and letting them actually live their life in a productive way and, live a happy, content life. It's a real struggle. So what are some new therapies out there, Steve, that, could help with that?
More recently, there have been some successes in the muscarinic agonism, which is what our company works with. And also there's something called the TAR1, or trace amino acid receptor, that Snovion had been working on, and that also looks promising. So all of a sudden, after decades, we have some things that really appear to be working. Recently, of course, in our company, we had our first phase 3 study, which is an important milestone, was positive. It's an inpatient study. We actually have 2 treatment arms, which is a little different. One is a arm that's placebo, basically, and this is very typical for these kinds of studies. And one of the reasons it's inpatient, because it is a serious illness, and to make sure we keep people safe, having them inpatient is one of the ways that kind of allows that, and helps with the greater good without causing problems. And then we have what we call a flexible dose. So people, and this is how people are treated anyway. You start them on a lower dose and then gradually or quickly go up depending on what your circumstances are. So, and we treat people for 5 weeks. And we had an earlier study, a phase 2 study, that was quite promising. It showed very large differences between our drug and placebo in this 5-week period. The primary outcome is on a scale that's the positive and negative symptom scale for schizophrenia. And this is the typical thing that is used really for all these kinds of treatments. And so we had very large differences. And then when you break it down, it was in positive symptoms as well as negative symptoms. And then in addition, we had some testing of cognition, which also looked promising. Actually, the main drug we work with, which is xanomeline, it's part of what we call CAR-XT, CAR for Karuna, X for xanomeline, T for trospium, which is to help make it more tolerable and safe, which is turning out very nicely. And it was first a cognitive drug. So we've known the cholinergic system is involved in cognition, but the psychosis business is only in the last decade that we figured that out.
That's great about the clinical trial data. Can you tell us a little bit about the mechanism of action behind the therapeutic?
Sure. Thanks, Hansa. This is a muscarinic agonist. It's an M1, M4 preferring agonist. So it probably benefits from both. M1 is purportedly the source for cognitive benefit, and M4 purportedly for antipsychotic benefit. But we don't know enough about the brain, and both may be contributing on both sides. So this is really a different way from the traditional antipsychotics, although the cholinergic system does influence dopamine and vice versa. So it is a more indirect way, I would say, of getting to the same circuits that apparently really cause great efficacy and reasonable tolerability.
What else is interesting about the phase 3 trial, Steve?
Yeah, well, the main thing was that it really confirmed the great data we saw in our phase 2 trial. So you have very strong efficacy as well as very reasonable tolerability. So there's no safety issues that we have seen so far in this program. And most of the adverse events people have are very short-lived and are not all that problematic. So this has been really a great data set and looks quite promising.
The caregivers, the families, is there anything you would add to help them?
There's a lot of stigma with this disease and people misunderstand it. So I would encourage families to get informed about it so that they're not subject, or they'll know how to handle some of this prejudice that gets out there, unavoidably in some ways, and to know better how to help their loved ones, because I think that can be quite helpful. And become informed consumers. There's a lot of information out there. It can be guided by NAMI and other groups that can help with this. And there's a lot of medical information. Some of it is hard to get through when you're a lay person, but there's a lot of good things now out on the internet.
Thank you again for the time you've taken today.
Great. Well, thanks for talking to us. It's a bad illness, but I think some really unique and different treatment is on the way. So
I'm excited today to talk about mental health innovation with Dr. Armin Szegedi. Armin, thank you so much for being here.
My pleasure. Thank you.
Well, before we launch into so many subjects that you are obviously an expert in, I'd love to hear a little bit about your background.
I am currently the Chief Medical Officer and Head of Clinical Development at Sunovion Pharmaceuticals.
How did you decide to become an expert in these areas, do the work you're doing? What was the process?
Thank you for the question. That's something I like to talk about because this has been truly a choice by passion to become a psychopharmacologist. I was trained in Germany as a psychiatrist, studied medicine, and went through the regular motions. And in that process, I came across something that interested me a lot. It was the fact that you could have therapeutic effects with simple chemical entities, small molecules, on people with serious medical conditions, schizophrenia, depression, bipolar disorder, and others. But it always interested me, particularly the area of mental health, the area of human suffering, and how that can be helped with, alleviated. As a psychotherapist, that's a natural thing that drives many psychotherapists, but I discovered that psychopharmacology is an area that is probably vastly underexplored and holds many promises for the future, and nicely complements also psychotherapeutic approaches as we have seen in the last couple of decades. So that was my passion and continues to be my passion also until today, and driving me to do what I'm doing.
That's so interesting. And it's great that you are following your passion. When you follow your passion, good things certainly come out of that. So getting a little bit into the disease states that you talked about, let's talk a little bit about schizophrenia. Can you give us an overview of schizophrenia, especially in the last few years, and its impact on patient lives as you see it?
Yes, of course. Schizophrenia is a complex, probably set of disorders conceptualized today as a serious medical condition, which often is a lifelong condition with different phases in affected individuals. And essentially, it's a serious mental disorder or a neuropsychiatric disorder that affects the way a person thinks, the way how a person feels about him or herself, but also the world around, and drives also behavior in very characteristic ways over the time. It occurs with remarkable consistency in all societies across the globe. Essentially, you can say your lifetime risk is about 1% or 1 in 100 people will be affected by a disorder. And it is often very, very burdensome in the sense that it impairs your ability to live a self-determined, productive life that many other people take for granted. So it's something that poses a whole lot of pressure on the families affected, the individuals affected, on their need to be assisted at certain times in order to have an acceptable and comfortable life. And therefore, it is one of the major areas of interest for every psychiatrist. Yeah, the point is that we have a lot of treatments. Thankfully, we have a lot of treatments for about, 60 plus years now, when the first antipsychotic drugs were discovered essentially by clinical observation and lucky chance rather than guided development. And those drugs, in principle, still dominated the next 6 decades of what kind of drugs were developed. Those were essentially, in a way, variations on the original theme. First, typical antipsychotics were discovered and developed, and later, for the last 2 decades or so, also atypical antipsychotics. They have various pharmacological profiles, but still they all have in common that most of them work much better on the positive symptoms, on delusions, hallucinations, irritability, and aggressive behavior. They work less so on the dimensions of negative symptoms and cognitive impairment. And also, there is a substantial number of patients who do not respond sufficiently in all of these domains. So they are difficult to treat patients occur. So there is still a huge unmet medical need for those for whom we don't have adequate treatment, but also for those who are treated. The available treatments often come with a certain burden of side effects. It's a very complicated area. And for many patients, there is a whole lot to be gained if we find more effective and better tolerated drugs for the future.
So what are some pathways to avoid these? You talked a lot about the side effects and also the issues of the cognition. Can you tell us a little bit about the work you're doing in this space?
So the work we are doing at Synovion is, I would really say, we are one of the pioneers in the field who strive for true innovation. And we do so by developing a wide range of molecules in-house to target serious medical conditions. In schizophrenia, one of the recent developments that were discovered in-house are the TAR1 agonist family of compounds, which have shown in a phase 2 study very good safety and tolerability, and potentially also some effects on the negative symptom domain. So ulotaront is our compound that is most advanced at the moment in phase 3 development based on the phase 2 data that I briefly summarized. And that is a novel approach to treat psychotic disorders and schizophrenia in particular that is unprecedented. In other words, it's a pharmacological mechanism that does not reiterate the 6 decades of dopamine direct receptor modulation, but addresses the trace amine associated receptors.
One of the barriers that can sometimes exist between innovation and adaptation in clinical practice is just the clinician uptake of this new information. We're at an exciting era. There's a lot of great potential interventions coming out. How can we get clinicians understanding this and adapt and the adaptations of so patients can benefit?
I do think that a whole range of opportunities have opened up in, let's say, the last decade or so, since we have the ability to communicate, for instance, as we do now, via video calls, via even conference attendances that can be virtual nowadays. So in other words, there is a whole set of media possibilities that allow you from your office or from your home to access medical information that can truly change your clinical practice.
Thank you so much for being here. Before we end this conversation, we just wanted to ask you if there's anything else that you'd like to share with our audience of doctors, nurses, clinicians that you think is important about, the future of not only mental health, but schizophrenia.
I wanted to thank all the colleagues around the United States, Canada, but also in the entire world where they may listen, for their continued dedication to treat the individuals who are affected by schizophrenia and other mental health disorders. I know that you're doing a very important and also very demanding job, because having been a clinician for more than 10 years myself, I do understand how individuals vary and how much effort one has to put as a therapist into guiding and treating these people to allow them to have the best possible life.
I completely agree with you. We should just take that pause and say thank you for all of the work you're doing, because it is such important work. And Armin, thank you so much to you for all the research you're doing and the development, and for being here with us today.
Thank you very much for having me. It's been a pleasure. Thank you.
Dr. Meyer, thank you so much for being here.
Oh, my pleasure. Thank you for having me.
So can you tell us a little bit about yourself? Our audience, I'm sure, is very interested.
So my area of interest broadly has been psychopharmacology of severe mental illness. I tend to focus more heavily on schizophrenia and bipolar disorder. And I like to talk a lot about how we treat schizophrenia, the use of medications for treatment-resistant schizophrenia like clozapine, drug kinetics, and also new developments in these areas, which I think are very, very exciting.
Yeah, absolutely. Can you tell us a little bit, just to set the background, to set the landscape, what are the unmet needs in schizophrenia? What are the challenges?
Well, we now recognize schizophrenia is a disorder which has three fundamental parts. We've been very good for the last, 60 some odd years at treating positive symptoms in most, but not all. Negative symptoms and cognitive deficits really remain uncharted territory. We sometimes will improve negative symptoms when we treat acute positive symptoms, but the term for that is pseudospecificity, meaning I make your positive symptoms better, but in people who have stable positive symptoms, we're often not very good at treating negative symptoms. Cariprazine has a study versus risperidone showing some benefit. There's some other things we sometimes use, but not a lot of options there. And for cognition, really, there's nothing.
What percentage of patients do you think are not effectively treated for schizophrenia or any of those components of schizophrenia?
Our best data overall is on symptom reduction, broadly speaking. If you use the PANSS or the BPRS and look at criteria for response, we would say almost a third of people are treatment resistant, meaning they don't respond adequately to non-clozapine antipsychotics.
That is very challenging, but I am understanding that there is a little bit of good news in terms of innovative therapies. Can you talk a little bit about that?
Well, we've known for a long time that while dopamine dysfunction may be a central part of both the positive symptoms and the negative symptoms and cognitive deficits of schizophrenia, we may be able to modulate that system in different ways. And so for many years, there was the glutamate hypothesis, as we called it. We knew that if we gave NMDA antagonists like PCP or PCP analogs, we can cause cognitive disruption, and we can also cause positive symptoms that really resemble schizophrenia. We haven't been real successful at developing glutamate-based drugs for schizophrenia, but people haven't given up on that. And more recently, we've had a couple of really major innovations. One of them is what's called a trace amine associated receptor 1 agonist, so a TAR1 agonist. And TAR1 is an intracellular receptor, and one of the things it does is it likes to heterodimerize with other things like D2. And people figured out that there was an association between TAR1 polymorphisms and schizophrenia, and they started studying it. And finally, we came up with some TAR1 ligands, which in animal models looked like they might be antipsychotics. And now, of course, these molecules, and the first one is now in a phase 3 trial. So what's exciting about this? Like, okay, so what does this mean for the patient and for the clinician? We think TAR1 does a couple of things. For one thing, it does not directly bind to D2, so we don't see those dose-dependent D2 effects like we see with D2 direct binding drugs. The second thing is that it seems to do some of its work presynaptically by decreasing presynaptic dopamine release. And that's kind of an exciting new mechanism, which we really haven't had a lot of in the world of schizophrenia, unless you go back to these old drugs like reserpine, which moderated presynaptic dopamine release, but was very poorly tolerated. Also, TAR1 agonists do seem to moderate the signal postsynaptically, but not directly affecting how dopamine binds to D2. So you have a confluence of things which portend to be really exciting, both in terms of efficacy on positive symptoms, as it's shown in a phase 2 trial, but the preclinical looks really interesting. So models for depression, TAR1 agonists make that better. They improve cognition. Again, these are non-human studies, but very exciting. And they actually seem to improve a metabolic profile, not only reversing the effects of metabolic offending medications, but maybe even just improving it from baseline. So a lot of really cool stuff there, which we never had before.
What else is interesting that's been on your radar lately? I love talking to you, Jonathan. This is so exciting.
Well, the other thing, and this really is an exciting development. So we are taping this now in August, and on August 8th, we had a very exciting press release from a company called Karuna. They have a molecule called xanomeline, which actually is spelled with an X, which is delivered together with another agent, trospium. I'll explain why that is in a second. But they reported data from their phase 3 trial. So this is a molecule that moderates presynaptic dopamine release, and it does it by a muscarinic mechanism. Thinking, well, how does this possibly work? So this is a muscarinic M1 and M4 agonist. So people will wonder, well, how do we even think this might work for schizophrenia? Well, there's a couple of lines of evidence which converged on this. Partly is that this compound was originally developed for people with Alzheimer's disease. They thought, oh, it'll have some M1 agonism. We'll make them smarter as much as we can. Well, it didn't work out so well in those clinical trials, but they found that it actually reduced active psychosis symptoms. And when people stayed on it, those who weren't psychotic developed psychosis at lower rates than those who were randomized to placebo. And so some people said, wow, this is pretty cool. And they actually took it into a very small trial in 2008 with literally 20 people who had schizophrenia, and it worked. But the problem is because it's a muscarinic M1 agonist in the periphery, not so well tolerated, lots of GI adverse effects. But they had this human exposure data which said this thing might work for schizophrenia. The other lines of evidence came from studies in animals. So once people started to get a sense that maybe muscarinic agonism does something for psychosis, they could create M1 knockouts and M4 knockouts in mice. So these are mice which don't have either a functional M1 or M4 receptor, and they have the phenotype of schizophrenia. Pretty cool. And guess what? If you look at human beings with schizophrenia, they also have a deficit in muscarinic M1 expression. In some instances, about 25% of people have less than 25% of the normal amount, meaning they have a 75% reduction in M1 receptor expression. So the idea is we have a lot of things which are pointing to the fact that this is something value in schizophrenia, and muscarinic problems might be a core problem in schizophrenia.
With all of these innovations that are happening, and this is very exciting, especially for patients who've waited so long for these treatments, how do we get the word out there? How do we make sure that our clinicians know about this even after the FDA approval and the research has been shown that it's beneficial?
Yeah, I think part of it is recognizing we're in a time of revolution in the treatment of schizophrenia. For years, the paradigm has been, let's set up a brick wall with a D2 receptor. It's been useful. I mean, it got people out of the state hospitals. That's fine, but we've recognized the limits of that. We now have 2 models for moderating presynaptic dopamine release, which don't carry the baggage of D2 receptor blockade. Also seem not to have the metabolic issues, which some agents have been tagged with as well. I think just people hearing broadcasts like this, talking to their colleagues like there's some exciting things that are going to be available. And for the compounds anomaly and trospium, also probably not until 2024. But this really is an exciting time to be in the world of schizophrenia, because we've had things in developments that we've never had since the 1950s. And for a lot of our patients, it offers hope that maybe at least we can improve in terms of tolerability, which is often a big win, but in some there may be some efficacy differences, which we will have to demonstrate in clinical trials. But I think it portends a whole new paradigm for how we treat this illness.
Yeah, no, it is definitely exciting and interesting, and certainly hope. Hope is really important. So thank you very much, Dr. Meyer. Thank you very much, Jonathan. And I look forward to talking to you about this more at another time.
Thank you so much for having me.